The blood pressure? Number. Millions of seniors are chasing may be wrong. Right now, more than 50 million Americans over the age of 65 are actively managing their blood pressure. Every morning, they take their medication, they watch their salt intake, they check the numbers on the blood pressure monitor sitting on the bathroom counter. And almost all of them are chasing a target number they were given during a doctor's appointment. But what if that number is actually putting some seniors at greater risk than the blood pressure they started with? That isn't speculation. It's what a growing body of cardiovascular research has been suggesting for years. And the reason most older adults have never heard this explained clearly isn't because their doctors don't care. It's because a 15-minute office visit was never designed to have a nuanced conversation about a topic this complex. I'm Dr. Thomas. I specialize in cardiovascular health and aging, specifically how the circulatory system changes after age 60, and what those changes mean for blood pressure management. Throughout my work with older adults, I've noticed a pattern. Many people have been faithfully managing their blood pressure for years. They follow every instruction. They take every medication exactly as prescribed. Their numbers look perfect on paper. Yet, they still feel exhausted. They're dizzy when they stand up. They feel mentally foggy in the afternoon. They struggle with fatigue that sleep doesn't fix. And often, nobody has connected those symptoms to the medication sitting on their kitchen counter every morning. This video is not about fear. It's not about telling you to stop your medication. It's about understanding the full picture, the picture supported by modern research, because the next conversation you have with your doctor should be based on information, not assumptions. Stay with me until the end because you're about to look at your blood pressure numbers very differently than you did when you clicked on this video. And that understanding could be important for your health. Why so many seniors feel frustrated. There is a specific kind of exhaustion that settles in after years of managing a chronic condition. Not the dramatic kind that sends someone to the emergency room. The quiet kind. The kind that slowly narrows your life. The morning walk becomes a little shorter. The afternoon feels a little harder. The grandkids' soccer game feels more exhausting than it used to. Then, one morning, the blood pressure monitor shows a slightly higher number. Immediately, the worry begins. Did I eat too much salt yesterday? Am I doing something wrong? Should I call my doctor? That constant vigilance can be exhausting. And for many seniors, another question quietly sits in the background. What if the number I've been told to chase was never actually designed for someone my age? That question deserves an honest answer. And the answer begins with understanding what blood pressure actually measures. Why blood pressure changes with age. Every blood pressure reading contains two numbers. The top number, called systolic pressure, measures the force against your artery walls when your heart contracts and pumps blood. The bottom number, called diastolic pressure, measures the pressure between heartbeats while the heart is resting and refilling. For much of the 20th century, doctors focused primarily on the diastolic number. Medical textbooks in the 1970s treated elevated diastolic pressure as the primary warning sign for cardiovascular disease. But research eventually changed that understanding. By the late 1990s, scientists had clearly established that for adults over 50, systolic pressure was actually the stronger predictor of heart attacks, strokes, heart failure, and cardiovascular death. Why? Because arteries change as we age. When we're younger, healthy arteries are flexible and elastic. They expand slightly with each heartbeat, helping absorb pressure and smooth blood flow throughout the body. Think of a flexible garden hose. But over time, those arteries gradually become stiffer. The elastic fibers break down. Calcium deposits accumulate. The artery walls lose some of their ability to stretch. Instead of acting like a flexible hose, they begin behaving more like rigid pipe. When the heart pumps against stiffer arteries, pressure rises more sharply because there's less flexibility available to absorb the force. As a result, systolic blood pressure often increases. Meanwhile, diastolic pressure may remain stable or even decrease. This creates a condition called isolated systolic hypertension, an elevated top number with a normal or low bottom number. And for adults over 65, this isn't uncommon. In fact, it's the most common form of hypertension. The problem is that isolated systolic hypertension is physiologically different from the hypertension seen in younger adults. Treating both conditions exactly the same way can create problems. And that's where the story becomes important. The study that changed everything. In 2015, a landmark federally funded study known as the SPRINT trial changed the way doctors thought about blood pressure treatment. More than 9,300 adults at elevated cardiovascular risk participated in the study. Researchers divided them into two groups. One group was treated to a traditional systolic target below 140. The second group was treated aggressively with a target below 120. The question was straightforward. Would pushing blood pressure significantly lower produce better health outcomes? At first glance, the answer appeared to be yes. Participants in the intensive treatment group experienced fewer heart attacks, fewer cases of heart failure, and fewer major cardiovascular events. The results were so compelling that researchers stopped the trial early. Soon afterward, major medical organizations updated their blood pressure guidelines. Millions of Americans suddenly found themselves being told to aim for lower targets. But here's the part most people never heard. The intensive treatment group also experienced significantly more complications. Researchers observed higher rates of acute kidney injury. Dangerous electrolyte imbalances became more common. Episodes of fainting increased. Falls requiring medical attention occurred more frequently. And when scientists looked specifically at older and more physically vulnerable participants, the balance between benefit and harm became far less clear. The researchers themselves acknowledged this. So did subsequent analyses. And geriatric specialists have been pointing it out ever since. The lesson wasn't that lower blood pressure is always bad. The lesson was that one target may not fit every patient, especially not older adults. Unfortunately, much of that nuance disappeared from public discussion. What remained was a simple message: get below 130. And millions of seniors have been living under that target ever since, many experiencing side effects that nobody connected to their blood pressure treatment.